So it is 1981, and a doctor and a judge are looking at the exact same dying man. And the doctor looks at his charts, observes his behavior, and says he is gravely ill. We must hold him in this hospital to save his life. But then the judge looks at the exact same man, confirms that he sleeps under a concrete freeway overpass, and says, well, he has shelter. He is free to go.
Right.
Which just, I mean, how does a concrete bridge become a legal prescription for liberty?
It is one of the most profound paradoxes in modern public administration, and it's really the precise contradiction we're going to tear apart today.
Welcome to our deep dive. If you're a public policy student sketching out, your very first legislative proposal, or maybe you're a social worker navigating the really brutal realities of these systems today, our mission here is to equip you with the analytical frameworks you need to actually evaluate long-term housing system efficacy.
What?
We want to help you cut through all the political noise, right? And just look directly at the structural machinery underneath. And to do that, we are trying something a little different with our source material today.
We are. We're going to treat this like two doctors basically thinking out loud. Consider this a grand round style diagnostic. But, instead of diagnosing a single patient in a hospital bed, we're diagnosing a complex systemic societal pathology.
Right.
We're looking at the crisis of homelessness in America, treating the data, the laws, the terminology, all of it, as the symptoms and vital signs of a much larger condition.
So let's start our grand rounds with the patient zero of today's diagnostic. That striking piece of firsthand medical testimony that I mentioned at the top. This comes from a dossier compiled by a physician named Nick Mattenzi. The year is 1981. We're in San Jose, California at the Santa Clara Valley Medical Center. And Nick is this young first-year medical intern.
Just starting out.
Right, just starting out. And he and his attending medical team are treating a young man who is, by every clinical definition available to them, entirely unschooled.
Yeah, and we need to be very precise about his clinical presentation here. This patient is deeply, profoundly disorganized. He is entirely unable to care for himself. He isn't just struggling, right? He is in a state of acute crisis.
Yeah.
In the specific language of the hospital and the state, he meets the clinical criteria for being gravely disabled.
Gravely disabled.
Right, so he's been brought into the emergency department on a 72-hour psychiatric hold. That's a mechanism designed to give the medical staff this tiny window to stabilize a patient who is in immediate danger to themselves or others, or who simply they just cannot survive on their own.
And the medical team, they do their job. They stabilize him as best they can, but a hospital is not a long-term care facility, and that 72-hour clock is, it's merciless.
It's ticking down.
It is ticking down. It is about to expire. And the medical team looks at this young man, and they know with absolute clinical certainty that if he walks out those sliding glass doors, he is in immediate life-threatening danger. He has no capacity to navigate the world, so they do the only thing doctors can do in that situation. They petition a judge to extend the hold.
Right.
They're asking the court for permission to keep the patient in the hospital longer, against his will if necessary, purely for his own safety.
And this moves us from the clinical environment into the courtroom procedure. And this is where the diagnostic criteria completely change. Because the judge is not a doctor.
No.
The judge is not looking at a medical chart or considering a broad ethical question of human well-being. The judge has a highly specific statutory checklist to get through, which is dictated by state law. So the judge asks the mandated questions. Can the patient feed himself? Can he clothe himself? And finally, the judge looks at the young man and asks the ultimate question, where do you live?
And the young man, he's disorganized, his thoughts are fragmented, but he is honest. He looks right at the judge and says, under the I-280 bridge, near the hospital.
And the judge listens to that answer, consults the legal standard in front of him, and issues a ruling that changes everything. The judge rules that the concrete I-280 freeway bridge constitutes an ability to seek shelter.
Wow.
Because he can technically seek this concrete shelter, he is not, in the eyes of the law, utterly incapable of surviving. Therefore, the judge denies the extended medical hold.
The gravely ill young man is discharged.
Exactly. He is sent right back out the hospital doors, back to the freeway overpass.
Reading this in our source materials just stopped me dead in my tracks because it forces a fundamental question about the systems we build. How can medicine and the law look at the exact same patient in the exact same room and reach completely opposite yet entirely legally correct conclusions? The doctors are screaming, he is dying, we must keep him. And the legal system is saying, well, he has a bridge, he is free to go. It feels like a glitch in the matrix of how a society is supposed to function.
But the thing is, it isn't a glitch. It is the system operating exactly as it was legislated to operate. And this raises the single most important diagnostic question of our entire deep dive today. When a person is both severely sick and completely shelterless, is their primary crisis located in their mind, or is it located in the absence of anywhere to live?
Right.
Was this young man's fundamental emergency his untreated psychiatric condition, or the fact that the society he lived in offered him a concrete overpass instead of a room, and then legally defined that overpass as a home?
That is the core tension we're dissecting today. And to understand how a judge in 1981 could look at a concrete overpass and call it shelter, we have to move away from the bedside and examine the underlying legal machinery. We have to look at the etiology of the laws that made that ruling inevitable. Because if you are a social worker listening to this, you know deeply that these structural barriers are not historical trivia. They are the exact same barriers actively paralyzing your care decisions this morning.
Absolutely. To diagnose this machinery, we have to rewind our timeline just slightly to establish the legal bedrock of that 1981 ruling. The etiology of this specific legal framework brings us to California's Lanterman-Petrus-Short Act.
The LPS Act.
Yes, the LPS Act. It was signed in 1965 and took full effect in 1972. And it's really impossible to overstate how radically this single piece of legislation altered the landscape of psychiatric care, not just in California, but as a blueprint for the entire United States. It sharply, aggressively limited the state's power of involuntary psychiatric commitment.
And I see that acronym, LPS, thrown around in policy papers constantly. This is the genesis of the infamous 5150 code, isn't it? The 72-hour hold itself?
Yes, exactly. The LPS Act created the 5150, the 72-hour emergency hold as a strict boundary. But more importantly, it established an incredibly high, almost insurmountable legal threshold for holding someone against their will beyond those initial 72 hours.
Okay.
That threshold is the definition of gravely disabled.
Yeah.
Now, as we act as diagnosticians here, we must look at the historical intent with strict impartiality. We have to steelman the arguments that built this system. The LPS Act was not written with malicious intent to abandon the sick. It was written by civil rights advocates and legislators to protect human liberty.
Because the alternative they were reacting to back then was a nightmare.
It was. It was a direct, forceful response to an era where people could be indefinitely institutionalized in massive state psychiatric hospitals, often referred to as asylums, with almost zero due process. I mean, a person could be locked away for decades simply for being considered different, difficult, or socially undesirable by a family member or a local doctor.
Wow.
Decades.
Decades. The conditions in many of these mid-century institutions were horrific. The state had immense, unchecked power to revoke a citizen's freedom under the guise of medical treatment. The LPS Act was designed to shatter that unchecked power. It was designed to ensure the state could not lock you away unless you were in immediate, undeniable peril.
But, I mean, keep trying to map this legal framework onto a physical medical crisis, and the analogy just kind of breaks my brain. Imagine a medical triage situation in an ER. A patient is brought in after a terrible car accident. They have a compound fracture in their leg, right?
Yeah.
The bone is visibly broken.
But the trauma surgeon is legally forbidden from setting the bone, casting it, or keeping the patient in a bed because the patient, despite their agony and delirium, can technically still drag themselves down the hallway and out into the street. It feels like we engineered a legal threshold where we are legally mandating a lack of care. Are we protecting their civil liberty, or are we simply protecting their liberty to suffer and die in public?
That is the exact friction point. It's the agonizing daily reality where public policy students and frontline social workers find themselves trapped. You are caught in a vice between a patient's desperate, obvious medical need for clinical intervention and their fundamental, constitutionally protected legal right to liberty in the absence of a structured home environment.
Because there's nowhere else for them to go.
Exactly. And the architects of the LPS Act, they envisioned a society where the closure of those massive state hospitals would be followed by a massive investment in robust, localized community mental health clinics. The idea was that patients wouldn't be locked away, they would be treated in their communities with supportive housing and outpatient care.
But the funding for those community clinics never actually materialized at the scale required, did it? The hospitals closed, the legal standard for involuntary commitment shot through the roof, but the localized safety net was just a ghost.
Precisely. The legal standard of gravely disabled remained fiercely intact to protect civil liberties, but the safety net required to support the people who met that standard entirely vanished. The system was hollowed out from the inside.
We really need to pause our grand rounds here and just do a quick impartiality check. Because when you look at the raw human suffering on the street, it is incredibly easy to demand a villain. It's easy to want to point a finger. I mean, if you are a doctor, your oath is to care for the sick. Watching a gravely ill, disorganized man wander out of your hospital and into highway traffic is a profound violation of your ethical duty as a healer. Your entire profession is built on the mandate to intervene.
Yes. But if you are a civil rights attorney or a judge sworn to uphold the Constitution, your primary duty is to protect citizens from state overreach. The concept that the government can lock you inside a psychiatric ward purely because a doctor decides you are making poor choices about where to sleep, that is terrifying.
Right, it's a massive overreach.
It is the definition of tyranny. Both of these perspectives are inherently valid. The medical perspective prioritizes the preservation of life and physical health. The legal perspective prioritizes the preservation of autonomy and constitutional liberty.
So the tragedy of that 1981 courtroom wasn't that someone made an evil decision. The doctors were acting ethically within their medical framework by trying to hold him. The judge was acting ethically within his legal framework by releasing him. The pathology is that the system forced a binary choice. Strip him of his civil rights and lock him up, or let him sleep under a bridge. There was no third option.
And that lack of third option is why the entire legal decision hinged on the definition of a single word shelter. Because the judge accepted the premise that a concrete overpass functioned as a shelter, the legal criteria for holding him collapsed. Which means, as diagnosticians of public policy, we have to talk about language.
Yeah, let's get into that. Because for the policy students drafting legislation right now, the vocabulary you use is not just academic window dressing. It actively shapes the legal and societal understanding of the crisis. And that understanding directly dictates the policy responses and the funding allocations. The language we use builds the walls of the maze we're trying to navigate.
It really does. Language in public policy is never neutral. It is structural. It carries embedded arguments and historical weight inside of it. So let's run a diagnostic on the terminology itself, starting with the massive recent shift from the term homeless to the term unhoused. For the vast majority of the 20th century, homeless was the universally accepted standard term in government documents, media, and public discourse. But in the last decade, there's been a concerted push across policy circles to replace it with unhoused. We need to analyze the specific mechanics of why this shift is happening.
Right, because it's definitely not just a polite rebranding or, an attempt to be politically correct. The core argument in our source material is about where the word places the blame. The term homeless quietly, almost subliminally, locates the problem within the person.
Yes.
It frames the condition as a personal trait and identity or even a moral failing. You are a homeless person in the same grammatical way you are a tall person or a quiet person or an angry person. It implies a state of being that you own.
Conversely, the term unhoused functions structurally as a verb that has been done to someone. It relocates the locus of responsibility away from the individual and places it squarely onto the system. It implies a society, an economy, or a government that has failed to house its citizens.
A failure of the social contract.
Exactly. You are an unhoused person, meaning the social contract has failed to provide you with the fundamental right to housing. It deliberately shifts the diagnostic lens away from individual behavioral choices and forces the observer to look at structural economics, zoning laws, and policy failures.
But what I found so fascinating in the sources is that this isn't a settled debate.
Yeah.
There are highly credible counter-arguments that we have to acknowledge. It is not a universal consensus even among the people living on the streets. There are advocates and current residents of large encampments who actively and vocally push back against being called unhoused.
What is their primary argument against it?
Well, they argue that even if they do not possess a physical structure with four walls and a house, they absolutely still have a home. Their community, their tent, the specific patch of sidewalk they maintain, their chosen family surviving together on the street, that ecosystem is their home. They argue that stripping them of the word home by calling them unhoused is actually deeply dehumanizing. It implies they are devoid of community or belonging, when in fact they have built incredibly tight-knit survival communities.
That's a powerful point. We also have to layer in the indigenous perspective, which the dossier highlights. Indigenous advocates point out that these terms land entirely differently in their communities. Given the historical trauma of forced relocation, broken treaties, and displacement from ancestral lands, the concept of a home is intrinsically tied to the land itself, to the community, and to the ancestors.
Not just a building.
Right, not simply to a Western concept of a permitted structure with a front door. For many indigenous people, you can be without a house, but you cannot be severed from your home in the same way.
And beyond the philosophical debate, there is a deeply pragmatic warning in the source material for anyone studying public administration. It's a phenomenon called stigma migration. This is a concept that every policy student needs to highlight in their notes.
Stigma migration is a critical diagnostic tool. It occurs when a society or a government changes a label, they update the vocabulary without doing the exponentially harder work of changing the underlying material conditions.
It's like treating the symptom on the chart without treating the infection in the body. If we just run a find and replace in all our city council documents, swapping the word homeless for unhoused, but we don't actually build any affordable housing and we don't open any psychiatric beds, the material reality of the people on the street doesn't change by a single millimeter.
Exactly. And because the material reality hasn't changed, the general public will eventually just take all of their old prejudices, all of their fears, and all of the stigma they associated with the word homeless, and they will simply attach it to the new word unhoused.
The stigma just migrates.
Yes. The relabeling becomes a dangerous substitute for action. It allows a city council or a policy group to feel incredibly progressive and compassionate because they updated their style guide, while entirely avoiding the brutal, expensive work of systemic change.
So, if the overarching labels are fraught, how does the system actually categorize the populations we are talking about? Beyond just homeless versus unhoused, the federal government and local agencies divide this crisis into very specific, rigid diagnostic categories. Let's talk about the difference between being sheltered and being unsheltered.
These are the fundamental operational categories used by the Department of Housing and Urban Development, or HUD. Sheltered refers to individuals who are temporarily staying in an officially recognized, sanctioned system. This means they are sleeping in an emergency shelter, a transitional housing facility, or a specific safe haven program. They do not have a permanent lease, but they have a roof provided by a formal system.
Okay, and unsheltered.
Unsheltered, on the other hand, is defined as individuals sleeping in places not meant for human habitation.
Which is the exact definition of our 1981 patient.
Yes, exactly. Living in cars, setting up tents in public parks, sleeping in doorways on commercial sidewalks, or seeking refuge under a concrete freeway overpass. That is the unsheltered population.
And this distinction is vital because the unsheltered population is what drives the public narrative. The unsheltered population is the visible symptom of the crisis that the general public interacts with daily. When a frustrated citizen goes to a city council meeting and yells about the homelessness crisis destroying the neighborhood, they are almost never talking about the single mother living quietly in a sanctioned transitional housing facility. They are entirely talking about the unsheltered population.
That's right.
That is where the most severe, untreated mental illness and the most chaotic visible markers of the addiction crisis are heavily concentrated.
That is precisely right. The unsheltered population is the tip of the iceberg that breaks the water's surface. But to truly understand the mass beneath the wire, policy students must grasp another set of definitions. This next distinction is arguably the most crucial analytical framework for anyone evaluating the long-term efficacy of a housing system. We must differentiate between transitional homelessness and chronic homelessness.
Let's draw a hard line between these two because the policy responses for one will completely fail if applied to the other. Let's start with transitional homelessness. From a data perspective, this is actually what the vast majority of people who lose their housing experience.
Correct. Transitional homelessness is typically a brief, temporary stint without a permanent residence. It is usually the direct result of an acute, sudden economic shock.
Like losing a job.
Right. A person gets laid off from their job and misses rent. A family faces an illegal eviction. A medical emergency results in a hospital bill that completely drains their savings account, leaving them unable to pay the security deposit on a new apartment. Or a person flees a sudden domestic violence situation with nothing but the clothes on their back.
The defining characteristic of a transitional case is the exit strategy. These individuals or families usually exit the crisis system relatively quickly. They don't need a decade of wraparound psychiatric care. They just need a bridge over the economic gap. With a little bit of targeted, temporary help, a short-term rental voucher, a one-time cash grant for a security deposit, or a few weeks in a family shelter while they secure a new job to get back on their feet. They find new housing, and critically, they do not return to the homeless system. They stabilize. Now compare that demographic to the definition of chronic homelessness. The federal government has a very specific, rigorous definition for this. To be classified as chronically homeless, an individual must have a long, extended, continuous history of homelessness, or multiple repeated episodes of homelessness over several years, combined with a formally diagnosed disabling condition.
The condition is the multiplier.
It is the anchor that prevents them from escaping the system. That disabling condition could be a severe, persistent mental illness like schizophrenia or bipolar disorder. It could be a profound substance use disorder, or it could be a severe, debilitating physical disability.
Right.
The chronic population is not just unhoused. They're profoundly unwell, and their illness makes navigating the complex bureaucracy of finding housing nearly impossible.
And the disparity between these two populations is staggering when you look at how a city allocates its resources. The chronically homeless population makes up a distinct minority of the total number of people experiencing homelessness on any given night. They are a fraction of the whole. Yet, they consume the vast, overwhelming majority of the crisis system resources.
It's the Pareto principle applied to societal failure.
Yeah.
The chronic minority accounts for the endless cycle of emergency room visits. They are the ones generating the constant daily police interactions. They occupy the long-term shelter beds for years at a time. They are the focus of the massive, expensive municipal sanitation cleanups of large encampments. The bulk of the public financial cost and the bulk of the intense, visible human suffering on the street is heavily concentrated in this specific chronic minority.
Which brings us to the most maddening logistical question for anyone studying public administration. If we have these incredibly distinct categories, sheltered versus unsheltered, chronic versus transitional, how on earth does the government actually measure them? How do we know the true scale of the pathology we are trying to treat? We can't put a city in an MRI machine.
No, we cannot. So we have to take the system's vitals manually. And the mechanism we use to take those vitals is both fascinating and deeply structurally flawed.
Right, let's unpack the measuring tape. Every year during the last 10 days of January, the federal government mandates a massive nationwide census called the point-in-time count, or the PIT count. When you look at the mechanics of how this is executed, it sounds like something out of the 19th century, not a modern data operation.
It really does. It is an immense analog logistical undertaking. Thousands upon thousands of volunteers fan out across every single county in the United States, armed with flashlights, clipboards, and digital survey apps.
Literally walking the streets.
Literally walking the streets. They walk through city parks in the middle of the night. They shine lights into parked cars. They hike into wooded areas looking for hidden encampments. They visit every single emergency shelter and transitional housing facility. They're attempting to manually, physically count every single person experiencing homelessness on one specific, usually freezing night in January.
And all of that raw data gets funneled upwards. It gets aggregated by local continuums of care, and then it is rolled up into HUD's annual homelessness assessment report, the AHRP. This report is then formally presented to Congress, and it is the primary instrument used to guide billions of dollars in federal funding and shape national policy.
It is an incredible feat of civic coordination.
Yeah.
But as diagnosticians, we have to recognize that it is an analytical nightmare. We must explicitly detail the severe methodological limits of this snapshot approach for our policy students. First, consider the time frame. A single night in January is just that, a single freeze frame. It captures who is homeless at 2 a.m. on a Tuesday. It entirely misses the massive churn of the system. It misses the family who was housed on that specific Tuesday but was evicted on Thursday. It misses the individual who was sleeping in a motel that Tuesday but ran out of money by Friday. Therefore, the total number of individuals who experience homelessness over the course of an entire calendar year is vastly, exponentially higher than what the PIT count captures on that one single night.
Not to mention the physical reality of trying to count humans who do not want to be found. If you're unsheltered, your literal physical survival often depends on remaining completely invisible. You hide, you seek out an abandoned, boarded-up building, you sleep deep in a brush-heavy wooded area where a volunteer with a clipboard won't venture, you park your car in a dark industrial park on the edge of town where the police won't tap on your window.
Exactly.
The volunteers, no matter how deeply dedicated and thorough they are mathematically guaranteed to undercount the unsheltered population because the population is actively, strategically avoiding detection.
And then we reach the most significant flaw in the instrument, which is a flaw of definition. The federal definition used by HUD for the PIT count explicitly and deliberately excludes families who are doubled up.
Explain exactly what doubled up means in this context.
Imagine a single mother with 2 young children. She loses her apartment because rent was raised beyond her income. She has nowhere to go, so she calls her sister. Her sister lives in a small one-bedroom apartment. The mother and her 2 children move in, and they sleep on the floor of the sister's living room.
Okay.
They have no lease, they have no privacy, and they could be asked to leave at any moment. They're completely housing insecure. But under HUD's strict definition for the PIT count, because they are inside a residential structure, they are not counted as homeless. They're statistically invisible to this massive federal data set.
Which finally explains a discrepancy that has always driven me crazy when looking at municipal data. If you pull the reports from a city's public school district regarding the number of homeless students enrolled, that number is almost always massively higher than the HUD PIT count numbers for the exact same city in the exact same year.
Yes.
It's because the Department of Education uses a much broader, more realistic definition that explicitly includes those doubled-up families sleeping on couches.
Exactly. 2 federal departments looking at the exact same city, using different diagnostic criteria and generating entirely different realities.
So if you are a policy student right now and you know for a fact that the data you are being handed is structurally flawed, how do you actually use it? Are you just navigating the most complex social crisis in America by a fundamentally broken compass?
You are not navigating by a broken compass, but you absolutely must know how to calibrate your readings. Here is the analytical framework you must adopt. You must read the PIT count as a definitive floor, never as a full head count. It represents the absolute minimum number of people experiencing homelessness on any given day. It is not, and never will be, a comprehensive census.
A floor, not a ceiling.
Exactly. However, because the flawed methodology remains relatively consistent year over year, they make the same mistakes in the same way every January. You can rely on the data to establish a trend line. The PIT count tells you accurately which direction the water is flowing, even if it is structurally incapable of telling you exactly how many gallons of water are in the flood.
Okay, so let's look at what that trend line is screaming at us right now, because the data from the last 2 consecutive years is giving the policy world severe whiplash. Let's start with the January 2024 count. The PIT count recorded a record 771,480 people experiencing homelessness on a single night. That represented an 18% jump from the previous year.
18%.
To contextualize that for a moment, that is the largest single-year percentage jump ever recorded since the federal government modernized the counting system. The trend line didn't just go up, it went vertical.
It was a systemic shock to the entire public administration apparatus. The end of pandemic-era eviction moratoriums and emergency rental assistance programs created a massive wave of new entries into the system. However, as diagnosticians, we must look at the anomalies in the data. Even within that devastating 2024 spike, there was one critical bright spot that every policy student should circle in red ink: the population of homeless veterans.
The overall number spikes 18%, but the veteran numbers tell a completely different story.
Exactly. Homelessness among veterans actually fell by nearly 8% in 2024, dropping to a record low of just under 33,000 individuals nationally.
I have to push on this. Why did that one specific, highly vulnerable demographic experience a significant drop while every other demographic category in the nation spiked simultaneously? Did the economy just magically work better for veterans?
No, the economy didn't change for them. What changed was the structural intervention. That 8% drop is the undeniable empirical evidence of the efficacy of a 2-decade, hyper-targeted, massively well-funded federal effort. The Department of Veterans Affairs partnered directly with HUD on aggressive housing-first initiatives specifically designed for veterans. They deployed dedicated housing vouchers known as HUD VASH, and crucially, they coupled those vouchers with extensive wraparound medical and social services provided by the VA.
So it wasn't just handing them a key, it was handing them a key and a caseworker.
Yes. It proves a fundamental thesis of public policy. When you align massive political will, dedicated, uninterruptible funding streams, and a targeted clinical approach, you can actually drive the numbers down, even when the broader macroeconomic weather is terrible. You can build a seawall for a specific population.
That is a crucial lesson. Okay, so that was the 2024 spike. And then we received the data from the January 2025 count, which was just finalized and released in May of 2026. And the trend line snaps back. The national number dropped to 745,652. That is roughly a 3.3% decline nationwide. It is the very first time we have seen a national decrease in overall homelessness since 2016.
Right.
And in some key states, the drag was even sharper. California saw a 2.8% decline. New York recorded a massive 7.9% drop. As a layperson, you look at those top-line numbers and you think, fantastic. The new policies are working, the economy has stabilized, the tide is finally turning.
But here is where we must act like rigorous doctors, looking beyond a patient's temperature to read the full blood panel. Here's the crucial, devastating caveat in the 2025 data. You have to look underneath that top-line number to see what is actually happening within the demographics. Despite the overall 3.3% drop in the total population, the rates of chronic homelessness and the rates of homelessness among adults aged 65 and older continued to rise.
Let me make sure I'm grasping the magnitude of this. The overall number of people on the street went down, but the number of people who are severely ill, deeply entrenched in the system, and elderly, those numbers went up.
That is exactly what the data reveals.
So the people who are the hardest to help, the ones requiring the most intense intervention, are getting harder to reach.
Precisely. Families and youth, the transitional populations we discussed earlier, were able to exit the system. This was likely due to recovering economic factors, cooling inflation, and highly specific state-level rental interventions in massive markets like New York and California. The transitional population caught a break. But the people carrying the heaviest, most compounding burdens, the elderly outliving their fixed incomes, the individuals with severe, untreated mental illness, the people trapped in profound addiction cycles, they did not exit the system. They are slipping deeper into the crisis.
That's terrifying.
A rising chronic number amidst a falling overall trend is a massive flashing red warning light for both the housing sector and the healthcare system. The most vulnerable are being left behind as the rest of the cohort recovers.
Which brings us perfectly to the core pathology of this entire deep dive. We have analyzed the legal history, we understand the language and its stigmas, we know the massive scale of the numbers, and we understand the structural flaws in how we count them. Now we must do the hardest part of the job. We must diagnose the root cause. Why are these numbers so catastrophically high, and why do they fluctuate the way they do across different geographies?
This leads us directly into the most entrenched political and sociological debate in modern American policy. To understand it, let's clearly set up the rival hypotheses. Let's call them Camp A and Camp B. Camp A looks at the visible, undeniable suffering on the streets of our major cities, the erratic behavior, the open drug use, the visible psychiatric distress, and they conclude this is fundamentally a health and behavioral problem. The crisis is driven by untreated severe mental illness and a catastrophic, unprecedented addiction epidemic.
And then you have Camp B. Camp B looks at the economic spreadsheets, the inflation data, and the real estate markets, and they say, no, you are looking at the symptoms, not the cause. This is fundamentally a housing problem. Rent is too high. Wages have stagnated for decades, and vacancy rates for affordable units are practically non-existent. People are simply priced out of existence.
And again, for our policy students listening, you must maintain strict impartiality here. If you walk into a legislative drafting room firmly, ideologically entrenched in only one of those camps, you are going to write bad, ineffective policy. You cannot legislate based on narrative. You must legislate based on data. And the sources in our dossier point us towards some groundbreaking paradigm-shifting research published in 2022 by Greg Colburn and Clayton Aldern in their book, Homelessness is a Housing Problem.
This research is the fulcrum of our entire diagnostic today. What exactly did Colburn and Aldern do that was so revolutionary?
They did something vital and elegantly simple. They took the health and behavior hypothesis Camp A's argument, and they rigorously tested it against the geographic map of the United States. They asked a basic scientific question. If severe mental illness and drug addiction are the primary systemic drivers of the overall rate of homelessness in a community, then the cities and states with the absolute highest rates of addiction and mental illness should naturally have the highest rates of homelessness.
The map of addiction should perfectly overlay the map of homelessness.
Oh, exactly.
But they don't overlay, not even close. That is the mind-blowing part of this research. The pushback here is just pure astonishment at the data. Look at a state like West Virginia. By almost every tragic metric available, West Virginia has experienced some of the most staggering, devastating, and concentrated rates of the opioid epidemic and addiction in the entire country. The per capita overdose rates are heartbreaking. If addiction directly created mass homelessness, West Virginia should have sprawling encampments stretching for miles across every town.
Right.
But it doesn't. Despite a severe addiction crisis, West Virginia has a relatively modest rate of homelessness.
Now, compare that reality to cities like Seattle, Washington, or San Francisco, California. If you look at the public health data, these cities do not have substantially higher rates of per capita mental illness or substance use disorders than the national average. They are not statistical outliers in terms of addiction, yet they have severe, overwhelming, internationally recognized crises of homelessness. So Colburn and Aldern asked, what is the variable that changes between West Virginia and San Francisco? If it isn't the rate of addiction, what is it?
The rent, it's the rent.
It is the rent. The systemic housing costs and the localized vacancy rates are the ultimate, undeniable predictors of the scale of homelessness in a region. Colburn and Aldern's data conclusively proves that regional housing markets, the basic, unforgiving math of supply and demand for a physical shelter, dictate how many people in that region will be pushed out of the housing market entirely.
I love the analogy the source material uses to synthesize this data, and I want to expand on it because it makes this incredibly dense statistical argument so clear. Think of a city as a body of water, and the housing market sets the water level in that pool. In a place like West Virginia, the housing water level is very low, housing is cheap, it is largely accessible, the pool is shallow. So if you live in West Virginia and you are struggling with a severe addiction or you lose your job because you're experiencing a mental health crisis, you are absolutely struggling. You are treading water. But because the pool is shallow, you can still touch the bottom.
Right.
You can probably scrape together a few $100s a month for a cheap room, or you have family members who have extra affordable space who can take you in. You are suffering, but you are housed.
But if you take that exact same person with the exact same vulnerabilities and you move them to San Francisco or Seattle, the environmental physics change. The housing costs in those cities are astronomically high. The vacancy rates are near zero. The water level is 20 feet deep. You cannot touch the bottom.
Right. And in a 20-foot deep pool, who drowns first? That is the synthesis. That is the grand unified theory of this crisis. Colburn and Aldern's housing data answers the question of scale. How many people fall into the water? But it answers a fundamentally different question than the judge was trying to answer in that 1981 courtroom. Housing costs dictate the massive scale of the crisis, but personal health, trauma, and addiction dictate who falls.
This is the critical breakthrough for understanding the entire system. If a city has a brutal, unforgiving housing market with zero vacancy, someone is mathematically guaranteed to lose the game of musical chairs. When the music stops, someone will not have a seat. But the loser of that game is not selected at random. The people who slip first, the people who land the hardest on the pavement, and the people who stay on the streets the longest are disproportionately those carrying the compounded, heavy burdens of mental illness, physical disability, and addiction. The macro housing market applies the crushing pressure. The micro-personal vulnerabilities determine exactly where the human system breaks.
And as doctors analyzing this, we cannot ignore the horrific feedback loop of the street itself. Being unsheltered is not a neutral state of waiting. It is profoundly, actively traumatizing. Even if someone ends up on the street purely for economic reasons, a transitional case, the daily reality of that life takes a toll. The constant exposure to violence, the total lack of restorative sleep, the poor nutrition, the elements, and the sheer unending psychological terror of basic survival will actively worsen existing conditions or completely create new mental health and addiction crises. You might not have been clinically sick the day you lost your apartment, but you will almost certainly be sick after a year of sleeping on the sidewalk. The street is an engine that manufactures the chronic condition.
Which brings our grand rounds to a close and brings us back to our series thesis. These two massive drivers, the crisis of individual health and the crisis of systemic housing, are not competitors in a political debate. Camp A and Camp B are both right, but they are looking at different layers of the same disease. They operate at entirely different levels of the pathology. You cannot solve a deep-water housing crisis by only treating addiction. The water is still 20 feet deep. And you cannot heal severe schizophrenia simply by handing someone keys to a new apartment without any clinical support. They will drown in the isolation.
The thesis of this deep dive is a roof and a hand. You desperately need the massive systemic infrastructure of affordable housing to lower the water level for everyone, and you simultaneously need the intensive clinical intervention to reach into the water and help those who are already drowning.
Let's bring this full circle back to that 1981 courtroom in San Jose. Look at that gravely ill young man standing before the judge through this new framework. He needed both the roof and the hand. He needed the roof of a systemic housing safety net, so his only option wouldn't be a concrete overpass. And he desperately needed the hand of continued mandatory psychiatric care, because his mind was entirely disorganized and incapable of navigating his own survival.
But because of the strict structural legal barriers of the Lanterman-Petrus Short Act, which completely paralyzed the medical team from intervening, and because of the total absence of a systemic housing solution to offer him a real bed, the system offered him neither the roof nor the hand. They offered him a concrete bridge, and they legally defined it as liberty.
And the ghost of that 1981 ruling echoes directly into the courtrooms of today. When you look at the modern, ongoing legal battles right now, cases that are currently marching all the way to the Supreme Court over the legal definition of homelessness, over the constitutional right to sleep in public spaces, over the legal authority of a municipality to forcefully clear a massive encampment, they are all arguing over the exact same structural tension. What constitutes adequate shelter? What is the limit of civil liberty when a citizen is actively dying in a public square? How do we balance the autonomy of the individual against the obligations of a society?
After all these decades, we are still locked in a courtroom trying to figure out if an overpass is a home. So if you are that public policy student or that frontline social worker we've been talking to, I want to leave you with a final thought to mull over as you close this deep dive and go back to your case files, your spreadsheets, and your legislative drafts. It's a dark question, but a necessary one to ask if you are going to change anything. If our laws actively require a human being to degrade to the terrifying point of being gravely disabled before they can legally receive mandatory life-saving care, but our regional housing markets are built on a mathematical certainty that the most vulnerable among us will inevitably end up on the streets, are our modern legal and housing systems actually broken? Or are they working exactly as they were structurally designed to, functioning together as a highly efficient joint mechanism of systemic abandonment?
Apply this diagnostic framework, the scale versus the who, the roof and the hand, the symptom versus the etiology to your work. Demand more than binary answers to complex societal pathologies.
Thanks for diving deep with us. Keep questioning the system.